Assalamualaikum and good afternoon to everyone who are joining us today. Welcome to our school students, teachers, parents from all around Malaysia, and not forgetting all UMS students and staff present in this session today. My name is Hayati binti Jaini. I am from Faculty of Psychology and Education. We'll be in charge as a moderator for this session. So thank you, and we meet again for today's session of STEM Speaker Series. For those who join us for the first time, today's STEM Speaker Series is a co-joint effort with the Faculty of Food Science and Nutrition University Malaysia Sabah and has the full support of the Sabah Ministry of Science, Technology and Innovation, aimed to deliver unique and interesting STEM topics designed by subject matter experts to increase the interest of school students, teachers and community alike to venture in the fields of STEM. For any questions from audience today, please feel free to drop your questions in the comment section. And please be informed that for today's session, e-certificate will be given to school and UMS student, but must fill in the form, which will be shared at the end of the program today. So please stay tuned with us until the end of the session. So before we start, allow me to introduce our dearest guest speaker for today. We will be hearing a presentation and a talk from Dr. Muhammad Firdaus bin Muhammad Hayati, a graduate from University Malaysia Sabah, UMS, with a bachelor's degree in Doctor of Medicine from the Faculty of Medicine and Health Science, UMS, on 2008. He then furthered his studies at University Kebangsaan Malaysia in the field of general surgery and successfully obtained the title of Doctor of General Surgeon in 2017. He previously held the position of Head of Department in the Department of Surgery and Deputy Dean, Research and Postgraduate in the STEM faculty. As an academic, he is very active in journal writing, and to date, he has published more than 160 academic publications. He has received the UMS Researcher Award 2020 and Top 4 Prolific Author 2020 in the UMS Researcher Awards 2019 until 2020, apart from other publication awards at the faculty level. Hence, without further ado, please welcome Dr. Muhammad Firdaus bin Muhammad Hayati, who will be speaking to us with his topic, Awareness on Cancer of Colon and Rectum. Doctor, please be invited.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Miss Moderator. Especially, I would like to thanks you Sains University Malaysia Sabah for inviting me to give this talk. I hope that this talk can benefit all the audience, especially among the community as well as those school goers. Allow me to share my slides. Is it visible now?
Yes, Doctor.
Okay. Okay. Thank you again. The title given to me is about cancer. So I was thinking, what should I talk about? As you guys know, cancer is very common nowadays. Among the most common cancers nowadays in the worldwide, including Malaysia, Sabah, is breast cancer for women and also colon cancer for male. And hence the talk that I will give today is about awareness. What should we know about cancer of the colon and rectum? Okay, my name is Muhammad Firdaus. I'm the general surgeon and also a medical lecturer in the Faculty of Medicine and Health Sciences, University Malaysia Sabah. I've been working since 2008, and now I'm practicing in Queen Elizabeth Hospital as well as in the University of Malaysia Sabah. Okay, before I start, I would like to declare that this talk has no conflict of interest. I'm not representing any drug companies or medical companies and so on. So this is for the public, for the community to enjoy and to have knowledge. Okay, I think it's common for us to come up with a quiz or any questions before we embark into any talks. So hence I list down a few questions. Maybe the audience might benefit before this lecture. Before I proceed with the talk, certain question might be in your mind. Number one, you guys wonder what are the functions of large bowel, and how common is colorectal cancer in Malaysia. I will keep on using the short terms, CRC, which means colorectal cancer. And how do we categorize risk of colorectal cancer? Low risk, moderate risk, high risk. And what are the most common screening techniques before we diagnose somebody with colon cancer? And lastly, what are the modality of treatments that we can offer to the patients who suffer from colorectal cancer? Okay, I think some of you knows the cartoons that this gentleman drew. Okay, this is Snoopy. I think most of you know Snoopy, Charlie Brown's. This is the artist, Charles M. Sclutz. Basically, he's the artist or the designer for Snoopy. Why I put this picture is because he suffered from colorectal cancer. Okay, I think you guys know who's this gentleman is, right? The 40th President of United States of America, Mr. President Ronald Reagan, former presidents. He also suffered from colorectal cancer. And then Mr. Abu Bakar Jua, he passed away because of colorectal cancer as well. Okay, Mr. Kuswadinata, also our former actors. I think your generation might not know about them, but if I put this picture, I think everybody knows, right? This is Chadwick Boseman, our Avenger. I think he passed away in 2020 because of colon cancer. So, that's life, right? At least from our part, we must know and we must be aware. Certain diseases can affect us. People can die because of cancer. So what should we do? We must be aware and we should take early prevention for it to happen. If we do have certain risk factors, then we need to take actions as early as possible. Hence, this talk, I hope that it will be beneficial for all of you here. Okay, before we proceed, I think it's good if we know a little bit about our body anatomy and also the functions of bowel. Okay, this on my left side, this is the picture. This gentleman, picture of a food pipe. We call it as esophagus. And then this is the stomach. When we eat, we chew, and then the food will go down into the food pipe, and it will go into the stomach. Stomach will change, will make it smaller, and it will go to the small intestine or small bowel. What happened in the small bowel? It will again process and digest and absorb all the nutrients. Once it has finished, it will go into the large bowel. Okay, this is our large bowel. This is another picture of large bowel. It's very long, roughly around 1 meter to 1.2 meters as compared to small bowel, which around 2 to 3 meters for each individuals. What's the main function of large bowel as compared to small bowel? Just now I mentioned small bowel to absorb nutrients. But for large bowel, basically, there are few functions of it. The most important one is it will help our body to absorb water. Okay, the water that we consume in the food, once it's being absorbed, it will go or it will be transmitted into the large bowel, and the bowel will absorb water. And at the same time, after it absorbs the water, it will keep inside the large bowel before it will be evacuated out as feces. Okay, this is the rectum and anus. This is where the feces go out. So if I want to show you here, our main concern here is colon and also rectum. Bear in mind that both are different entity. Okay, because any cancer that happen in the colon, the treatment is different as compared to cancer in the rectum. Okay, the management is different. So if we talk about cancer of the colon and rectum, basically we are talking about cancer of the large bowel and rectum. Very minimal percentage of cases whereby there's a cancer happen in the small intestines. Cancer of the colon it signifies cancer of the colon and rectum. Okay. Okay, this is the smaller picture. If we take the bowel and then we look at under microscope, okay, this is how it looks like. Very tiny layers. It consists of this is, we call it as mucosa. Okay, the innermost layer of the bowel wall, followed by submucosa. And then we have muscles which help to contract, to help to bring the food towards the anus. This is the muscle. This is the functions of the muscles, circular muscle and also longitudinal muscles. And lastly is serosa. So we are talking about 4 important layers of the bowel wall. So what is the most important layers here? If you talk about cancer, usually cancer will arise from the mucosa. It will arise here first. Not inside here, not inside the muscle, not inside the serosa. It will be inside here. That's why any screening process, it must any problem, it will appear through the content of the feces. Hence, the screening, the modality that we use to know whether any patient has suffered from cancer or not. The early occurrence, we will have any abnormal mass coming from these layers. Okay. Okay, then we talk about a bit about the how common the cancer is. This is the epidemiology study about the community, the public. If you see here, this is our the map of the world, and according to Global Can 2018, you see here is color coded. This is Malaysia. So I can say that maybe from 100,000 cases, I can say maybe 25 to 32 cases of colon cancer in Malaysia alone. So it's quite common. What about cases of a death or mortality? In medical, we call it as mortality, or patient died because of cancer. And then, okay, again, quite a dark colored grading color. Maybe from 100,000 cases, 10 to 12 people died because of colon cancer. So that's the statistic shows or reads or portrayed by itself. Well, when we talk about cancer, any cancer in Malaysia, we are referring to this cancer registry. This is the latest one, 2012-2014. It will be published every 4 years. Maybe the latest one 2017 to 2021. We're waiting for that. So this is the data based on this registry. Malaysia National Cancer Registry. Okay, this is the list of 10 most common cancer for Malaysian for the past for 4 years between 2012 2014. So where is colon cancer? Okay, it falls under number 2. Okay, yeah, after breast, then followed by maybe this one lung cancer. Okay, and so on. Okay. So it's a bit scary, yeah. The statistics a bit scary, yeah. 13.5% of all cancer in Malaysia. Okay, another statistics. Okay, among male, how common is colon cancer? I think I mentioned it earlier. First slide just now, 14.8%. 14.8 people per 100,000 population. Okay, meaning that among, I can say if 100, if we have your class, you have 100 people, 100 students inside, maybe 14 of the students will suffer from colon cancer. So it's a bit scary for male. What about female? More or less the same, 11.1 patients from 100,000 population. Okay, then we talk about the age. What will be the age specific occurrence of colon cancer? First, among males, okay, you see there's a sloping, high takeoff of cases from 45 to 60%, 60 years old. Okay, as compared to earlier. But if you see here also, current generation is that current cases of colon cancer, it tends to divert towards earlier age group, meaning that those with 20, as early as 20, 30 years old, they can suffer from colon cancer. Not only 50 and above, it can happen earlier. In fact, I found patients, 17, 18 already had colon cancer. What about female? I think same goes to female. 45 to 60 years old, there's a sudden takeoff of the number of cases. Okay, what about the ethnicity? Okay, ethnicity. Okay, if we see here, okay, I didn't highlight it. It keeps on increasing from past 4 years. You see here, which one is the most common one among Chinese? Okay, so the statistics says by itself. Among Chinese, then followed by Malay, okay, and then followed by Indian. Okay, yeah. What about stage? When we talk about cancer, we always heard about stage 1, 2, 3, and 4. What does it mean? Okay, basically stage 1 is very early disease, meaning that if we do screening for whatever cancer, breast cancer, colon cancer, and then suddenly notice there's a pathology, there's a lesion without any symptoms. Very early disease. So it can be considered as stage 1. If let's say the cancer is already involved the part of the whole bowel wall, maybe this is stage 2. For stage 3, maybe the cancer already involved the whole layer of the wall, plus there's a lymphatic involvement. Lymphatic lymph nodes. It acts as a policeman. Any infection, any cancer, there's a protective mechanism of the body. It tends, it will go through the blood, and this lymph nodes, like a policeman, it will capture them. So it will become enlarged. It's like a policeman, a police station, the jail. So it will be enlarged. This is stage 3. What about stage 4? Stage 4 is when the cancer already spread to the other organs, for example, liver, lungs, bone, and so on. So, based on this registry, how common, how severe is our cancer in Malaysia? So, between 2012 2014, there's a 4,800 cases. If you see here, most of the time, they will present in stage 3 and stage 4. Okay, what about female? Same numbers, stage 3 and stage 4. So what does it mean? It means that our community, our people, they tend to come late, not like the overseas, in Japan, in European countries, they come early, they come for screening, so that's why they can get a higher number of cases in stage 1 or stage 2. So if people comes with stage 3 and stage 4 is a bit delayed, not only affecting the patients himself, but it affects the institutions, the health institutions, in terms of the economy. We need more money to do surgery, more financial support used for chemotherapy, and so on. So if we do come early, the treatment will be minimally invasive, not a big operation required. Usually stage 1 or early stage 2, usually patient doesn't require chemotherapy. So there's the difference between early stage and also later stage. Okay, there's a study by our researchers in Malaysia. Why we are concerned about stages? Stage 1 until stage 4. There's no stage 5. If you watch a movie, suddenly they say stage 5. No, there's no such thing as stage 5. Only up to stage 4. So if you see here, if patient suffers from stage 1, you see the percentage of them to survive up to 72 months, almost 0.8% as compared to those with stage 4. So you see the number here, the graph here coming down trend. So the likely for them to survive up to 72 months is very minimal, 0.2% only. So that's why it's very important for us, for the patient to come early. Okay, another busy slides, statistics. When we talk about survival, usually we talk about survival, how long they can live, up to 3 years and 5 years. 1 year, 3 years, and 5 years. Okay, so if we see here, okay, this number, this stage, stage 1, 77 percent, 77, then they can live up to 3 years. What about stage 4? Only 33%. What about 5 years? Okay, stage 1, almost equal number, 72%. But stage 5, stage 4, only 22%. Okay, so there's a big gap, big difference between stage 1 and stage 2. Okay, why people develop cancer? It's still under study. The research has been going on and on and on. So the knowledge is keep on expanding. That's why we are here in the university, in the hospital. We want to study. We want to explore what happened. Why patient develop that? Why patient develop this? Okay, in general, usually when we talk about anything, we will talk about risk factors or etiology. We talk about non-modifiable as well as modifiable etiology or risk factors. Modifiable meaning that something that we can change. Something we cannot change. Modifiable, something that we can change. What do you think? Family history. Do you think you can change your family? Do you think you can change your mother, your father? No. Family history is non-modifiable risk factor for you to develop colon cancer. Meaning that if our grandmother, grandfather, father, mother, uncle, siblings, niece, and others develop cancer, has colorectal cancer, the likely for you to develop cancer is there. Okay. That's why if you go to the hospital, we like to ask this question. Father, mother has cancer or not? This disease, that disease, because it can run in the family. Okay, what are the risk factors? Okay, this is cigarettes, smoking. Okay, if you see here, 15 cancer that can develop after smoking. So you can name it everything under the sun, from top to down, everything. So if I'm the one who see this picture, this illustration, I'll be scared. We can get esophageal cancer, food pipe, kidneys, stomach, liver, lung, especially lungs, and so on. Not only primary smoker, I mean, you are the one who smoke, but it can cause secondary smoker, meaning that those who not smoking, but their friends, their families smoke, this is considered as secondary smoker, can also develop cancer. Okay, come back to our topic. Can cancer develop after smoking? Yes, it's shown here. Even though it doesn't directly go to the stomach, to the colon, but it does. It can lead to colon cancer. What else? What are the modifiable risk factors? Okay, obesity, and also, processed food. This studies has been shown that obesity and also this processed food can lead to cancer. Sausage, what else? Burgers, all these canned food, and so on. So if you do like all this type of food, I know that is difficult. I also enjoy sometimes all this McD and so on, but try to take it in minimum. And with regard to obesity, we are encouraged to do exercise at least one day, 30 minutes for one day. This is the requirement that study has shown that can be a great help for us. Okay, what else? This is meat and is relation with formation of cancer. So as I mentioned earlier, what about with regard to processed food, sausage, hot dog, bacon, salami, and so on? It falls under group 1 category that can lead to cancer. So if you see here, it's very scary. It can lead to cancer. What about our meats, red meats, white meat, and so on? Okay, beef, pork, and so on. It falls under group 2A, which is probably causes cancer. So this illustration to strengthen about processed food that can lead to cancer. Again, those who live in a sedentary lifestyle, doesn't want to do exercise, doesn't want to jog, take processed food and so on, they are likely to develop colon cancer. This is based on the research. Okay, how to see? What will be the presentation of colon cancer? Maybe I can say that when any symptoms already developed, it's not considered as early presentation, early stage. Usually, if stage 1, early stage, it will be diagnosed or it will be discovered through a screening. Meaning that no presentation, no symptoms at all, we do screening, then it will be early disease. However, the moment they develop presentation, if I'm the one, I'll be quite scared, because maybe it's already stage 2, stage 3, and the worst is stage 4. Okay, what will be the presentation? They can develop anemia. Why they develop anemia? Because tumor, it tends to bleed. Okay, especially colon cancer. There's a sometimes patient they develop change of bowel habit. Initially the bowel habit, they pass motion once a day, then suddenly it becomes different. 2 to 3 days once, or the worst one is if let's say they can't bowel motion at all. It's already blocked. Okay, so cancer, it can bleed. So sometimes after pass motion, we can't really look at down there, right? I can't really see. But if let's say keeps on bleeding, patient can develop anemia, like low hemoglobin level. The symptoms, they can complain that they will have dizziness, easily tired. They will say that they have fast heartbeat. Okay, that kind of stuff. Uh, uh, and in addition, they also can develop abdominal pain. It's like a tube. The bowel is like a tube. Anything that lodged inside the tube, okay, it tends to, water cannot pass through. It tends to dilate. The behind one can dilate, behind tube. So uh just now you remember I show you the picture of the colon. It has a muscle. This muscle in the body, it will keep on contracting to help the feces or the bowel content to go out. So if let's say something inside there, in this case cancer, so the body will have a sensation of pain inside. And in certain cases, if let's say the lesion mass is already enlarged, sometimes patient can say that they feel something in the tummy, on the abdomen, in the abdomen. So usually if let's say there's a mass in the abdomen, I can say that is minimum stage 3 or stage 4. Okay. Okay, sometimes they can present with bleeding when they pass motion. Those who use toilet paper, when they wipe, they can see there's blood on the toilet paper, as well as sometimes in the toilet bowl itself. What will be other presentation? Sometimes they also have a perianal symptoms. Maybe some mass at the surrounding the anus, or they can have what we call in medical as tenesmus, in which this is a sensation when they feel that they want to pass motion still, even after they already pass motion, meaning that they keep on having the urge to pass motion, but in fact no more inside there, no more feces. It is actually because of a mass that lodged, that happened to be in the anus. It mimics like a feces. Okay, this one change of bowel habit, just I mentioned to you. Yeah, the polar of bowel motion is has already changed. Sometimes they have a hard pellets, hard stool, sometimes loose stool. The character of the feces used to be elongated, but now become pellet, small caliber type of feces. This you guys, we need to be worried. And because of cancer itself, it tends to, uh, in other words, it tends to eat our nutrition, because it want to grow. It will consume our blood. It will consume our nutrition, our oxygen. Hence, patient usually will have a sensation of loss of appetite. Because there's a alien inside the body that keep on consuming our food. And because of that, because we never eat, don't have appetite to eat, they start to lose weight. Okay. Okay, this is the alarming presentation, meaning that if you do have this type of presentation, you need to be worried. Okay, what are they? The first one, if you have unexplained rectal bleeding, meaning that it's not because of hemorrhoid boisir or anything else or injury or whatsoever. Unexplained rectal bleeding with more than one of the following. If let's say it's fresh blood, or the blood mixed with stool, with a change of your polar of your bowel habits, and together with a significant loss of weight, so you need to be worried. And or you have unexplained anemia, okay, tiredness, dizziness, lightheadedness, and so on. Or you have when you as I mentioned, mass on the abdomen or down there in the rectum or in the anus. Okay, how you categorize the risk for colon cancer? We divide it into three: average risk, moderate risk, and high risk. So the take-home message here, most important one is family history and age group. Okay, remember that. Okay, what about the first one is about average risk. Okay, if you don't have family history of colon cancer and you are aged more than 50 years old, you will fall under average risk. Okay, if moderate risk, you have family history of colon cancer, be it first degree, your father, your mother, your uncle, your grandmother, your grandfather, or your son, your daughter. Okay, this is first degree or second degree, and so on. So basically, we're talking about family history. Okay, what about high risk? High risk cause to develop colon cancer if you are aged less than 50 years old. I'm 40 years old. Suddenly, I have I'm has a risk of have a higher risk to develop colon cancer. Okay, okay. You have a family history for those who have less than 50 years old. Okay, okay. Or you have a family history, those with FAP. FAP meaning that there's some form of cancer in which they tend to develop many polyps. Later I show you what is polyps uh, in the colon, or these syndromes, or the sort of syndromes. Okay, we're talking about syndromes here. Again, I repeat, if you have a family history who has colon cancer less than 50 years old and also all these syndromes, okay, then you fall under high risk to develop colon cancer. Okay, there's an algorithm based on the Malaysian CPG, what should clinical practice guideline. So what should we do if we have symptoms or we don't have any symptoms? Okay, if you see, if we assess, if we don't have any symptoms, okay, then we stratify which category we are. Just now you remember got three groups just now: average, moderate, or high risk. Okay, remember, if you fall under average risk, okay, more than families more than 50 years old, and no family history, then you fall under average risk. So if you're concerned, you can go to the hospital, okay, and then we can do what we call as fecal occult blood test, in which we will take the feces, send it to lab, and then we will see whether there's blood inside the feces or not. If there's a blood inside, if negative, you can do it every year, no problem. If there is a blood inside, you need to undergo colonoscopy. We put the scope inside the colon. Okay, what about moderate risk and higher risk? High risk, okay, both. If you fall under this, then you need to do colonoscopy. Okay, simple. Remember. Okay, this is another just a repetition for what I mentioned just now. If you go to the hospital, we will ask you history. We will interview the patients. Ask everything under the sun. Until to the family history, you're smoking or not, you're drink alcohol or whatsoever. That's why doctors. We will we have we need to be we are bound to our profession. We are the one who can you know ask question the secrets from the patient, and we must be bound to that. You the patients usually believe that we will take care of them. So that's our profession. Okay, this is just a repetition. If you do this alarming symptoms, remember the three things I mentioned. Urgently, you need to be referred for endoscopy, for colonoscopy within 2 weeks. Okay, if you go to the hospital or to the clinic, you have this all these symptoms. Suddenly the doctors give you more than 2 weeks. You need to ask. You need to query about that. It should be within 2 weeks. If not fulfill this criteria, maybe you can do elective colonoscopy, meaning that is not that urgent. Okay, I mentioned just now, colon cancer cannot run away with family history. So if you do have this family history of cancer within 50 years old, or you have multiple cancers at whatever age, and cancer of the endometrium, your ovary, your stomach, your small bowel, and so on, at any age, then you need to have a genetic risk evaluation or family history of the syndrome that I mentioned just now. Okay, there's a scoring system that has been developed by our researchers recently, in which in 2011, in which this is a simplified scoring system, in which if you fulfill under certain points, you will fall under this category. Okay, we can go one by one. Basically, the risk factor that we look at is the age, gender, family history of colon cancer, first degree, and smoking. Okay, basically for age, what we see is less than 50, 50 to 69, and more than 70, male, female, no family history of colon cancer first for among the first degree relative, or whether you smoke or not. Okay, so those who are smoking, where is it? Okay, present. If you smoke, you already had score 2. If you male, some more 1. Okay, it's already 3. So you will fall under moderate risk. Okay, if you female, where is it? Okay, 0. Never smoke, 0. Okay, less than 50, 0. No family is 0. So you fall under average risk. So remember again, average risk. If you want to check, you can do fecal occur blood test. Just take the feces, send to look for any blood. If you fall under moderate risk or high risk, you need to do colonoscopy post screening. Okay, this is just a repetition. Okay, this is the fecal occur blood test I mentioned just now. So basically, it's like a test kit. So this is how we do. Take the feces, unscrew the cap, and then take it, put over here, okay, and then shake it, screw back, and then drop it inside here. Then we see this is the result. How to interpret one color. It's like like you do COVID test also. Very simple. Okay. Okay, this is colonoscopy. In which what we do is we will put a, a scope, a camera, a flexible camera inside the colon. It will be very long. as I mentioned, 1 to 1.2 meters of the colon. From here, the anus, where the feces out, goes here. There's a junction here and there, and then up to here on the right side, near the appendix. Appendix is here. This is the small bowel. So we will look at through the TV here. So before we do colonoscopy, of course, this is discomfort procedure. We will make sure everything goes well. The doctor who's going to do the scope will explain how they will do this and ask for agreement. We will sign a letter saying that we will agree. Among the things that we will tell the patient is we will need to make sure that the colon is clean. And there's a few complications that we hope we will try to avoid, but it can happen. The most common one, there's a bleeding, it can happen, or we are scared about perforation. You imagine, this is this is hard flexible scope. If we wrongly perform, we can puncture the colon. What we do is we insert, we blow gas so that it can be distended and we can visualize the inner part of the colon. And if we find anything, we will take biopsy and send for assessment. Okay, how to make sure that there's no complication? If you're scheduled for colonoscopy, we will ask you to drink a lot of. We'll give you medication. Ubat julap. If you know that, we in the form of sachet or 3-in-1 form, put in the water. You drink, and then you will clean the colon. You will push away all the feces out until clear. So by doing this, we hope that we might not miss any small lesion that can be visualized. We hope that we can avoid any complication. If we do blindly, because there's a feces inside. If we keep on the bowel is not clean, we keep on forcing to push, there's a risk of perforation. So usually, if we think the bowel is not clean, we will reschedule again. Okay, why I show this picture? This is C polyp. Okay, under the the sea water. You go down, you dive, and then you can see all this beautiful color polyp. Okay, this is like a polyp in the colon. Okay, but it's not as nice or beautiful like our normal colon. Okay, this is the picture when we do colonoscopy. Smooth, clean, nothing. There's no feces. Everything clear, fine. And then you can see something here. Just now you see, right? There's a like this, right? The polyp under the sea. Okay, like this. And if nothing happen, if you don't remove this, it will start to grow, become like this. You can see the wall, the surface become angry, and then you become more angry. Angrier than this one. This is cancer. In medicine, we call it as adenoma, carcinoma sequence. Remember that from this to this, it takes 5 to 20 years to develop. So you imagine if you do have, you go for endoscopy, you have this polyp, small polyp, we remove this, I can say that people, researchers usually like to say that almost 99 to 100%, you already remove the source of cancer. Okay. Okay, this again a picture of nice, beautiful inner side of the colon. Okay, you can see the bowel, the blood vessel inside here. There's a junction there that we need to go. Okay, this is the polyp. Okay, what we do is we take this piece of plastic, and then there's a net that we go around this. Then we cut it using electricity. In which this one we pull it down. So this is part of the layer. We burn it. We diatomize it. We electrocute it, and then it will drop. Where is it? I think this one. And then this one we need to take and send to the lab, looking for any cancer. Okay, bear in mind that this is the part where sometimes bleeding can happen. So we will make sure that there's no bleeding here. Okay, there's a one video. I can show you. There's no sound. Okay. Sometimes we can do what we call as narrowband imaging. We will shine, we highlight to see the, you see, angry looking, angry looking bowel wall surface. Then what we do is, you see, it takes practice to maneuver this endoscopy, colonoscopy. Our aim here, this is the area of interest. Okay, this is the tube that I mentioned just now. Okay, we check this polyp. There's no other polyp elsewhere. Okay, I think it takes time for us to bring the this one, the net. It's not a net. Okay, then we pull it down. Okay, then we burn it. Okay, then it drops off. Because of the angle is like this. Actually, this is the gravity. This up is, this is down, and then we flush looking for any bleeding. Okay, and then the piece of polyp that we mentioned just now, we take out and we send to the lab. Okay, that's all, simple. Okay, this is the as compared to one polyp just now, this is multiple polyps. This is the syndrome that I mentioned just now, FAP. Multiple polyps like a carpet. You sometimes we can see a carpet with, the rounded carpet like this, like that syndrome. Okay, this is a picture of, the colon. The nature of colon, it can bleed. This is bleeding. I think this is the lumen. So we will take part of the tissues here, send for lab. Okay, what will be the late presentation of cancer? Okay, if let's say, the tendency of cancer, it will grow. Either it will grow inside or it will grow outside. Okay, so if let's say it grows inside, it can obstruct the pipe, the bowel. Just now you see the bleeding, right? It can bleed. Patient can have a low red blood cell count. Sometimes cancer, sometimes it tends to burst. If they don't burst at the cancer site, it can burst at the area where it was distended colon. Okay, it can perforate, and then sometimes patient can come with stage 4 colon cancer. It goes to the liver. If let's say it goes to the liver, patient can develop yellow eyes, yellow skin, or it goes to the lung. They have difficulty to breathe, or it goes to the brain. They have seizure, epilepsy, and so on. Or it goes to the brain. It goes to the bone. They have back pain, fracture, and so on. Okay, if we suspect patient with colon cancer, the most is the easiest investigation that we can do is X-ray. This is X-ray of the abdomen. Seldom we do X-ray of the abdomen. Usually, if you want to come to the join new school, come to the university and so on, right? To get work and so on, get a new job. We will ask for X-ray of the chest, but this is X-ray of the abdomen. Okay, this is a picture that will be visualized if let's say patient develop cancer over the part of the colon, the earlier part of the colon. So this is a, you see this is small bowel. If let's say it visualized like this, it will be distended, dilated, located at the center. So, okay, next picture is as compared to this, it has like a stacked coin. If you susun a coin, it will be like a stacked coin appearance. But if you see here, it's different as this. Okay, it like a pipe, and then it has this whitish color. This is usually we talk about obstruction. There's a blockage at the in the large bowel. This is small bowel. This is large bowel. Okay, if we diagnose somebody with cancer, what should we do? I think I mentioned this earlier. Cancer, we cannot treat, especially colon cancer. We cannot treat just by medication or just by wait and see. No, we need to do resection. We need to take it out. We need to remove it out. Okay, either endoscopically or through the colonoscopy just now, or operation through minimally invasive, through a small keyhole surgery or open surgery. Okay. Sometimes, especially stage 3, stage 2 or stage 3, they require chemotherapy or radiotherapy. Radiotherapy usually before we do operation. Those medical students usually they know about this. What we call as neoadjuvant, meaning that we give radiotherapy prior to do surgery. Okay, and also for palliative purpose. Palliative meaning that it's already stage 4. There's a tumor there, bleeding, or burst, perforate. Then sometimes we do radiotherapy or surgery to remove that part. And if let's say in the case of advanced cancer, sometimes we do radiotherapy towards the bones, the lower part of the rectum and so on. It's important to say here, in the case of advanced cancer, it's not a single team approach, meaning that not only surgeon to take care of the patient, but it's a multidisciplinary team approaches in which patient will be managed by surgeon, by oncologist, the person that give chemotherapy, by psychiatrists if they develop stress, any psychological problem, by nutrition, by radiologists, and so on. So many things will be involved. Okay, this is the early cancer that I mentioned just now. Okay, from this as a polyp, we can say that it's quite a deep type of polyp, in which the doctor, the surgeon, or the endoscopist will inject some medication to make it elevate. You see, this is the original one. They put something, put a dye or put a medication to make it elevate, and then they burst here, here, okay, surrounding it, and then they catch the polyp again. Okay, and then is the final result. Okay. Okay, this is a real picture of the colon. This is the total colon. If you see here, patient has multiple, you see, polyp. This already resected, already removed. If you see here, this is whitish color lesion. This is the cancer. Small polyps here. I bet that if let's say we open it up, it will appear like this. Okay, this is cancer here. Okay, you see here whitish color things. Is very near to the. This is the anus. If it is different, I mentioned to you, the higher the level of cancer, the better it will be. However, if let's say cancer develop very near to the anus, we need to remove the anus together, meaning that patient will be bowel open or feces will go out through a bag on the abdomen. Okay, we will close the anus. Patient will not have any anus anymore. Okay, this is carpet of polyps. This is FAP. I mentioned to you. So why I mentioned about FAP? Studies have shown that if you have FAP, the genes that develop this FAP by the age of 20, 100%, you will develop cancer, colon cancer. So that's why it's very important to you to know this. Okay, again, this cancer here, this is a real picture. Okay, just I think I almost finished. Every year during March, this is our Hari Raya, colorectal cancer awareness month. March, in March, we will have a blue color ribbon. So again, just a repetition, in Malaysia, is the first among men, second among women. From 2012, 2016, 15,000 cases already diagnosed. And majority of them diagnosed quite late, stage 3 and stage 4. So what is polyp? Polyp is the first growth that develop before they develop cancer. So it's a benign, non-cancerous type, in which it's important for us to remove it before it become cancerous. Okay, if you have the history of polyp, you have likely to develop cancer. Okay, this is the gejala, signs and symptoms, rectal bleed, bowel habit, change of bowel habit, blah blah blah, and so on. So what can we do? Yeah, to avoid all these things, limit or avoid alcohol. Limit to 1 drink per day. This is the volume. Modify your diet. Limit intake of red meat or processed food. Eat more vegetables and so on. Be physically active at least 30 minutes per day, and then if get a screening. If you are smoking, stop smoking now. If you almost reaching 50, and then you know what to do. Come for screening. Okay, I think you remember again this post lecture quiz. What are the functions of large bowel? How common it is? I think until 1 to 5 at least. This 1 hour talk, you gain some knowledge, and you can answer these questions. I think that's the last slide from me. Keep calm and get the colonoscopy. Thank you very much. So 1 hour, okay.
Right. Thank you very much to Dr. Muhammad Firdaus bin Muhammad Hayati. It was a very interesting and wonderful topic, as well as very well presented. Now we would like to wait for the question by the audience. Maybe we can wait for 2 to 3 minutes, Doctor.
I cannot see a question here, right?
Uh, yeah, you cannot see it here, but the
Yeah.
admin will post it maybe on our chat box.
I hope this topic is not too advanced or too bombastic or too medical. I try to make it as simple as possible. I know that this is STEM, right? So this is our government's agenda to expose you guys towards science, technology, engineering, and maths, right? That STEM stand for. So yeah, at least I can cover something on science if possible.
Okay, Doctor. It looks like we have not received any questions. So if that's the case, maybe we can end our session today. So we hope you all enjoy this amazing and interesting presentation by our wonderful speaker today. And the link for registration and e-certificate is now being shared for school and UMS students. So please fill in your details and answer the simple feedback questionnaire. So thank you again, Doctor, for the amazing presentation. And thank you also to all of the audience today for your participation. We look forward to seeing you in the next STEM speaker series Penamaan Nangka 27 of May 2022, 18 March at 2:30 p.m.
Okay, thank you very much. Thanks again, you Science, UMS, for calling me.